Well, good evening, everyone, and welcome to the Brian Crombie Radio Hour on Saga 960. I have the privilege of interviewing some fascinating people, and tonight is going to be no different. I want to introduce you to Dr. Mamdani, who is a professor in the Faculty of Medicine at the University of Toronto. COVID has really tested our healthcare system in Canada and, frankly, around the world. And so far, we haven't been, I don't think, overwhelmed, but one of the issues that we clearly need to address in flattening the curve is making sure that we don't overwhelm the healthcare system. Dr. Mohammed Mamdani believes that artificial intelligence, AI, and data analytics technologies are set to revolutionize hospitals and healthcare delivery in this country. And so I wanted to reach out to him and understand that. Dr. Mohammed Mamdani is the professor, as I mentioned, in the Faculty of Medicine at the University of Toronto. He is also the first to be named the Vice President of Data Science and Advanced Analytics at Unity Research, the Toronto Audette Chair in Advanced Analytics. Dr. Mamdani, welcome. Thank you for joining the program.
Thank you. Thank you for having me. It's a pleasure to be here.
So congratulations on all that you've achieved. Maybe you could just give me a sense, what is the VP of Data Science and Artificial Intelligence at the University of Toronto do?
Yeah, so my role at Unity Health Toronto is Vice President of Data Science and Advanced Analytics. It's the first of its kind in the country. And I think it culminated because we're quickly realizing the importance of data and advanced analytics, things like artificial intelligence in healthcare. We just have to look to other industries to foreshadow what's going to happen in healthcare because we are lagging behind in that respect. So for example, we've got the retail sector, and it's been radically changed by groups like Amazon.
Yeah,
it's incredible how it just magically knows what people want to buy next. And how does it do that? Well, it actually looks through millions, if not billions, of data points, and it matches patterns to people like you and says, this is kind of what they wanted to buy, and I kind of sense this is what, based on your patterns, what you may want to buy. So I'm going to suggest it to you. And I don't know about you, but whenever I go to Amazon, I look at it and it's pretty good in terms of what it recommends.
So is that good, or is that an invasion of privacy, or frankly both?
Yeah, it's a good question. I think there's a balance to everything, right? I would argue that if I'm in a pretty dire situation and you can save my life by poking into some of my data, I'm good with that. Now, on the flip side, if you're randomly going through my information to figure out my financial status without my permission, that's a bit of a different story. So I think there has to be a balance between privacy and public good. That's where we have to land.
I also wonder about it in politics and the use of some of this data to figure out, who people are going to vote for and label them as leaning one way or the other, and then either paying attention to them or no longer paying attention to them.
Yeah, that's a good question. I mean, there's all sorts of uses. And I guess part of it, to be honest, I'm not saying all of it. Part of it is our fault because I just have to ask people, when you actually go on your phone and you download an app and it asks you for all these permissions or sign off, how many people really read those things in detail? You just say, yeah, sure, I agree.
Yeah.
Well, you consciously agree to let people have your data. So why are you complaining about it later? Now, of course, some people will argue, well, I'm not a lawyer and I don't know how to read these things. Well, they don't agree to it. On the flip side, there are really cunning companies and groups out there who know you're not going to understand it or read it, and you'll automatically agree. So again, I think there's a bit of a balance. We can't.
Well, and I worry that some of the lawyers, frankly, write it so long and so confusing so that you don't bother reading it.
I'm sure, absolutely. There's a lot of that as well. So I think but it takes two hands to clap, right? So I think we've got to make sure that we're balanced in terms of who do we really kind of pin things on. There's motives everywhere.
So you've got an unbelievable resume. Can you run through a little bit of your expertise that brings you to this current situation?
Yeah, it's funny. I've always been interested in data. It's one of those weird quirks, I guess. I started out. I did a clinical degree. So during my clinical training, I was always questioning, well, why is it that we make these decisions? Because a lot of times I think it's just gut feel. I don't really see any real rational, valid reason to make X decision versus Y. And I've always landed on, well, it's got to be about some sort of evidence or some sort of data that will help me make decisions. early on, part of my undergrad was in psychology. I did a double major and things, and I learned about Miller, was a famous psychologist and did famous experiments in the 1950s and created something called Miller's Law. I'm not sure if you've heard of this, but Miller's Law suggests that the average human can process at the same time 7 plus or minus 2 things. And when you go into the clinical sciences and you're looking at patients and factoring in all sorts of things that can go wrong, there are way, way more than 7 things that one would need to process to really make good decisions. And that's where I thought, no, wow, we really need some help. So after my clinical training, I did a fellowship in health economics of all things, but ended up took classes at night while in the day I was in the hospital, and ended up doing a Master's of Arts degree in economics focused on econometric theory. And it sounds fancy, but really it's
Masters of Arts in econometrics?
Yes. I know, it sounds bizarre. And
sounds
actually,
bizarre. Should be Masters of Science in econometrics, should it not?
Well, it should be, but I actually wanted a pure economics degree because I didn't want non-economists teaching me economics. I wanted to learn economics from economists, and that's an MA in econometrics. And the problem is that I had to get an exception because I didn't meet a lot of the requirements for such, because I have a science and clinical background. But fortunately, they put me on probation, and I was able to do well in the first semester, so I was able to get into the program. But the concept is, I was writing mathematical proofs for 2 years. And don't get me wrong, it's not like I completely enjoyed it. It was pretty painful. But it taught me a lot around reasoning. And that's when I said, I like what I'm learning, but I can't translate the language into something people would understand or clinicians would understand. So that's when I decided I'm going to go to Harvard. I'm going to do an MPH, a Master's in Public Health, in Statistics and Epidemiology. And it's a little bit, sure, for the math, but it's more about the language and how you communicate with people.
What a fascinating background. And when was it that you were in Cambridge?
So I finished my degree there in 1998. So I was, fortunately, I was in a program where I could complete things in a year. So 97 and 98, and I was able to get my master's there.
I had the opportunity of going to school there as well. What a wonderful experience.
It's fantastic. It's such you have to be there. It's a different community, isn't it?
So I got to tell you, one of my relative back to your, Miller's Law. One of my very first jobs after I graduated from my undergraduate was with Keg Restaurants. And George Tidball, the president of Keg at the time, only wanted to have 7 items on the menu. And he said, people can't deal with too much choice. And he quoted Miller's Law. And that's why the Kegs initially only had 7 items on the menu.
I did not know that. That's very interesting.
You can use that. And then, Moses' Law, right?
Yes.
What's Moses' Law?
Sorry, Moore's Law?
No, Moses.
Oh, Moses. No. What's Moses' Law?
Well, it's not quite the same, but similar, which was if you want to say something, it can be on, if it's good enough for Moses, to be on 2 tablets, 10 points, and each point, other than one, was only 7 words long. So the 7 comes back into Moses, making it simple so people can understand. And if it was good enough for Moses, it's good enough for us.
I can very much appreciate that.
We're chatting tonight with Dr. Mohammed Mamdani. Am I pronouncing it right?
Mamdani. Yeah.
Mamdani, who is a professor at the Faculty of Medicine at the University of Toronto, talking really about artificial intelligence and data analytics. We're going to take a break and come back with the professor in just a minute. Stay with us. Well, welcome back to the Brian Crombie Radio Hour, Saga 960. We're chatting about artificial intelligence and data analytics tonight with, I guess, one of the top people in Canada, if not the world, in this regard, Dr. Mohammed Mamdani, who is a professor in the Faculty of Medicine at University of Toronto, and he's also the Vice President of Data Science and Advanced Analytics at Unity Research, Toronto Audette Chair in Advanced Analytics. Sounds like that's quite the mouthful. Doctor, Professor, artificial intelligence, how is that impacting or benefiting people in the healthcare system during COVID-19?
Yeah, that's a great question. I think artificial intelligence is one of those things where it has to have a lot to learn. And unfortunately, we don't know a lot about COVID-19 still. We're learning a lot. But the impact of AI is going to be not as dramatic as people might think in COVID because it has to learn still. That being said, there's lots of things that AI can do. So, for example, we have at our own hospital, we've implemented this at St. Michael's just very recently. How do we keep track of the homeless population, which is a very vulnerable group? And how do we, because typically what happens is somebody who's homeless comes in and says, okay, so I'm going to sit here for an hour or 2 or 3 or 4. No, I'm tired. I'm just going to leave. And they just tested positive for COVID-19, and then they're roaming around the streets being positive. Or they go to a shelter, which has had several cases of COVID-19 with the potential for an outbreak. Right now, the systems are so siloed where the doctors in the emerge and the nurses in the emergency department are really struggling to get all the information they need and to actually contain people when needed. Literally, it can take hours to get all this information from different systems. So at our end, what we've developed is something fairly simple that doesn't include a lot of AI right at the beginning, but it does a bit later, where what we've said is, why don't we actually create a process where within seconds instead of hours, it brings all the information you need at one point. And it actually tracks everyone who comes into our emergency department, understanding where they've been, who they've been in touch with, as far as we can, and which shelter or which home they've been at. And as soon as it recognizes, hey, I just saw this person 2 days ago, or there was somebody else from this other shelter that came in, I'm automatically going to send an alarm out to the doc, to the nurse, to the shelter, to public health, to let them know there's an issue here. In the past, when we've seen an outbreak, for example, at one of the shelters, it wasn't really caught quickly. And the only reason why it was caught was because there was a brilliant emergency doctor who remembered, I think I just saw 2 people from the same shelter over the past 24 hours. And that physician was astute enough to actually then sound the alarms. But we're relying on humans to do that. Now we have the solution in the background that's constantly monitoring that'll send out an alarm automatically to prevent those people to go out.
So it's better contact tracing effectively.
Yeah, absolutely. And, we're actually talking with our hospital folks now around how can we automate the contact tracing thing where, like literally within seconds, it'll actually be able to tell you exactly who's been in contact where and what those patterns look like, so you can more quickly respond. Instead of taking days, we can respond within minutes. And that should help.
Right.
Other things like even predicting volumes. For example, at St. Mike's, so we've also implemented this at 3 other hospitals, with another hospital going up soon, of how we predict how many people are going to come to the emergency department. So currently, we have this algorithm that uses machine learning techniques that counts for, I think it's about 4 years of historical data. We've got it pulling in weather data, so is there a snowstorm tomorrow night? We've got it pulled in city planning data. So for example, are the Raptors playing at the Scotiabank Arena tomorrow? Is there a marathon happening on Lakeshore Boulevard on Tuesday? It factors all of that in, and it predicts how many patients are going to come to the emerge. So for example, today's Saturday. We can tell you Monday from 12 to 6 p.m., there'll be 82 patients in the emerge. 10 of them will have mental health issues. 12 of them will be high acuity patients that need a lot of care. And the rest of them, lower acuity, probably easier to manage. We can do that with between 94 to 96% accuracy. And that's going to allow us, or that is allowing us, to actually staff better, so we can actually manage our patients better.
Fascinating. So you've also got a background in epidemiology.
Yes.
Some of these models that we've been subjected to in the news in regards to predicting COVID-19, I presume that's not something you're involved in right now, but you're probably pretty aware of?
Yeah, it's a good question. No, we haven't really gotten involved in a lot of the models that try and predict 3 or 6 months out what the waves are going to be for COVID. And the reason why we haven't done that is because I just don't know many models that actually get it right. And when I step back and I say, what are the foundations of machine learning and models and prediction? It's about predicting based on what we know. How a model learns is it says, okay, so this is what's been happening over the past few years. So based on all these patterns and trends, now I'm going to predict what's going to happen. In a pandemic type situation where we've never seen something like this, the chances are you're going to get it wrong. The model's not going to learn well. So instead,
Dr.
our group,
Tam, the head of public health, I guess this past week came out with a new model for Canada that we really warned of a second wave. And, you take a look at the linear regression or whatever the regression was. I guess it
yeah,
wasn't linear, it was power log. But the points early on in the increase in the curve fit pretty well. And I guess looking at what had happened in other countries, particularly I think Europe and Israel that opened up their schools before we opened up and opened up their economies, predicting a second wave with either current social distancing or improved social distancing, or worse social distancing that is far worse than the wave that we had in March and April, or April and May. And that the only way to flatten it was to take really stringent measures. Have you taken a look at that? Do you have an opinion?
yeah. So there's models that Canada has. There's models that the U.S. has. There's all sorts of models. Practically every country has models. And I would argue that I think these exercises are helpful, but it paints a picture of what could happen, and we don't really know what's going to happen. So for example, if we look at many of the earlier models, they were off by orders of magnitude. Right? It's because we didn't know. I think how the world reacted was to say, okay, but Australia is ahead of us, and Korea's had more experience than us, and X and Y countries are out ahead of us. So assuming that those patterns would translate here, let's learn from them. And there's been a lot more sharing of data, and I think that's helped the models quite a bit. The issue that becomes important to me is it's not just about the virus. I would argue that just as much, if not more important, it's about how we react to the virus. So a virus can be extremely deadly, but if we're social distancing very well and it can't transmit, we're not going to have as much of a problem. And how we react as humans is much more difficult to predict than how the virus is going to react to us.
I think you're right. Actually, I know you're right. But I come back to the very first model that I think was released was late March, early April by President Trump. It was a University of Washington model that predicted 140,000 deaths in the United States by August the 4th and over 200,000 by the fall. And then it was reduced dramatically a month later when it looked like social distancing had taken place in the United States, and then increased thereafter when a lot of the U.S. southern states opened up too early and the New York incidence was higher than they predicted. But that first model actually was pretty accurate.
Yeah, it was. And I would say that there were many, many models after that disagreed with it. And then you're kind of left in this situation of, well, who's right and who's lucked out to get the numbers right. I just don't know.
Okay, so you're the expert. Should we be worried or looking at these models, or what's the answer if we can't have confidence in them?
Yeah, my sense is I honestly, with these models, I don't know exactly what to believe. I think most of them will point to certain directions because they tend to look out at each other. And I would say it's good for us to prepare for what could be and then react to it. Because if we don't have any estimate, it's really hard. But I think what we should do is take these models and say, okay, this is a rough indication of where we're going to go. I don't know exactly if we're going to hit there. And it may be that, models are funny. If we were to say, I want to know by the decimal point what's going to happen, don't believe any models. You're not going to get there. If you want to know ballparks, I think we can reasonably get there, but it's not going to be definitive. So what models do, at least from my perspective, is give us some direction. And what we can then do is say, how are we going to react to that direction? We're getting a lot smarter now because we have a lot more data from other countries. And the Washington model, I think, was actually developed by some very, very bright people, and I think it was on the right track. But I don't think they knew how we were going to react or how the US was going to react. And now that we have an understanding, like, for example, we recently learned that anticoagulants will help people in the hospitals. We didn't know that before. We also recently learned that there could be very differential effects in kids versus adults. We didn't know that early on. We also recently learned a whole bunch of other things that we just didn't know, and it's still evolving. So the models will get better. It'll give us a rough indication of where it's headed, and it'll actually help us understand how we should react. Now, how we do react is a whole other question.
So, it's interesting, and I wonder whether artificial intelligence plays a role here, because we are learning a lot and very quickly and in a whole bunch of different areas. Initially, I think people thought this was just a respiratory problem, and now people are thinking it's a vascular problem, and it's potentially causing blood clots and potentially blood clots that travel to and or occur in the brain. And so therefore there's brain fog, and people are having cognitive issues longer term. You've talked already about the impact on adults versus kids. How does the medical establishment, gather all this information when, probably there's people that deal with respiratory issues and different doctors that deal with cognitive issues and different people that deal with vascular issues? How do you bring it all together? Is that machine learning? Is that artificial intelligence?
That's where AI can help. I think this is where, once we get to a position where we have enough data, we have enough learnings, we can train AI models to then learn on that data. In the early phases, I would argue AI is not going to be that helpful. Now, in the areas where it could be helpful, even in the early phases, are things like discovering vaccines or treatments, because we have an understanding of what the structure of the virus is. We have an understanding of what types of molecules would need to bind to certain receptors and such. That, I think, would have a lot of potential. But from a public health or from a clinical perspective, no, we need a lot of that data. And I think we're in a good position now to have some of it. What I would also argue, though, is that if there's another mutation, for example, that's a whole other new game.
Yeah.
If we, the second wave that we have, if it's actually affecting the young a lot more than the older, we still have some learning there. So the model, even the AI model, is not going to be perfect right now. But to your point, it will be better than what we have.
I saw this one study, I can't remember who did it, but it was comparing radiologists' ability to determine cancer from MRIs versus, I think it was IBM's Watson. And IBM's Watson was more capable over time of actually reading all of the MRIs and correctly determining where cancer actually existed or not. Have there been tests comparing the ability of AI versus real people?
Absolutely. So, in fact, I hate to keep using examples at our institution, but we actually are ready now to deploy a solution in medical imaging where the concept, again, very simple. I'm going to actually use the example of brain bleeds. So intracranial hemorrhage. The concept is a person comes to the emergency department. We see they have trauma or they have something to that effect where they need a CT, a computer tomography of the head. So it's just a scan of the head. And so we send them to the CT scanner. And the way the current process works, and it's not just at our institution, it's practically every other institution out there, is that by the time the CT scan goes into the system, the radiologist looks at it and gets to it, it's over 3 hours to make that diagnosis. So you can imagine a patient is sitting there in the emerge over 3 hours with a bleed in their brain.
Right.
It's not good for the patient.
Not good.
So, no, it's not. So we've just finished about 5 months of silent testing on this, and it works quite well. Where what we've done is we've created a process where there's a box and there's a lot of code where we actually grab the CT image, run it through an AI algorithm, and within a minute or two, it'll actually tell you, does this person have a bleed in their brain? If so, what subtype of hemorrhage is it? And where is it located? And it kind of makes a little circle in the exact location. It does this very, very quickly. And our concept is all we really need to do is then alert the radiologist and move that up to priority for the radiologist to review. And as we're deploying this literally in the next few weeks into clinical practice, we're anticipating we're going to get turnaround time from over 3 hours to under 10 minutes. And how does this perform versus clinicians? We know that it's over 90% accurate, and it's comparable to radiology predictions. That being said, we're not going to replace the radiologist with it. We're going to get it to assist radiologists.
We're chatting tonight with Dr. Mohammed Mamdani, I apologize, professor at the University of Toronto, and I guess a physician or on staff at St. Mike's as well, about artificial intelligence and machine learning. We're going to take a break and come back more with the doctor, the professor, in just a minute. Stay with us. Hi, we're back on the Brian Crombie Radio Hour, Saga 960. I come to you every Monday through Friday at 6 o'clock. I bring you interesting interviews with some fascinating people. We've had a lot of people on talking about COVID-19. We've had a couple of people from St. Mike's, and we've had a couple of people from University of Toronto. And so it's a pleasure to have Dr. Mohammed Mamdani, who is a professor at the Faculty of Medicine at the University of Toronto. I mentioned that he may have been a physician. He's not. He's a pharmacist, but he's also the Vice President of Data Science and Advanced Analytics at Unity Research Toronto, a DET Chair in Advanced Analytics. He's been at Wayne State University in Detroit, is it not? As well as Harvard University in Cambridge, Boston, Massachusetts. And he's got a Master's of Arts in Econometrics, a Master of Public Health, and a focus on statistics and epidemiology. So this man is a little bit smart. Professor, I understand that you said something about two obstacles stifling healthcare delivery. Could you expand? What are these obstacles and how are you going to solve them?
Yeah, there's actually quite a few obstacles, I think. One is around simple just collaboration in silos. And I can elaborate on that. And I think the second is really about our infrastructure and technology. So on the first, it's still pretty frustrating, I imagine, for a lot of patients when they get an image done from one place and another place says, I don't think we got that report. Could we do it again? Or going from one specialist to another and them not being able to share their notes as easily as they could and to repeat procedures. Lab work often gets done multiple times. I think fueling that is going to be the technology to be able to say, no, wait a minute, we did track this well and the patient did receive this care, so we don't duplicate efforts. But also collaborating between physicians, nurses, health professionals in general, and patients. So the two things, I think really the breaking down the silos that are there in our healthcare system, and it's tough, it's a really massive system for us to be able to integrate and work better. But the second thing around having the infrastructure and technology to enable that collaboration to be more effective are going to be two things that I think will be very important for us.
So, we had lots of people talking about e-health and computers and databases and stuff like that a couple of years ago that were, I think, interested in breaking down silos within the healthcare system. Is that what you're talking about or something different?
I think it's related. I think there's so many facets of collaboration here that I think are important. One is at the infrastructure and technology end, and that's why I was saying that more technical infrastructure part enables that collaboration. But the second is also the culture of collaboration, right? And so what do I mean by that? What I mean by that is that a lot of patients may be not so they may be intimidated, or they may just not feel comfortable talking to healthcare professionals. And maybe we need to create that environment where they are comfortable. Other situations where clinicians may not talk to each other because they're just used to doing their own thing. In fact, in a lot of training in healthcare professionals, you're really taught to be independent. I think that's changed over the past little while, and the newer generation is taught to be a lot more collaborative. But I know historically, like when I went to school, it wasn't about so much a team-based approach. It was about, you're seeing the patient, this is what you need to get it done. So culturally, as well as the infrastructure and the technology.
Is there more collaboration between patient and physician today? I think that the patients today are going in after checking out on Google or WebMD or wherever they go, a lot more information about their challenges. And I hear more and more about sort of online consulting groups that help you through your cancer problem or your whatever problem it is, and support groups. And it, in the past, it was almost like, we believed everything the physician said. Today, we want to debate with them and discuss with them.
Yeah, and I think a lot of that is healthy. I know a lot of people will disagree with me, but especially a lot of the healthcare professionals.
Especially a lot of the physicians that just want to get done and get on to the next patient.
That's exactly it, right? And part of it is because our healthcare system is set up where it's fee for service, where the more patients you see, the more money you make. The other part of it is where the culture of us being trained to say, no, we know a lot. And it's the analogy of, am I going to go to a mechanic and talk about carburetors with them when I know nothing about carburetors? I get that. But at the same time, I know my car. I know other things in the car. I know how I've driven it, and that I went over a pothole yesterday, and maybe I didn't tell the mechanic that. Maybe they'll figure it out on their own. Maybe they won't. But I would argue that it is a team sport. It's I would say that the patient knows their health in many cases a lot better than healthcare professionals do, because they live it every day. And the health professional will see them for 15 minutes, maybe, if you're lucky. So how can you really, really get an assessment of that? Maybe I can give you another AI example if that
Please.
helps.
Yep.
So in our neurology clinic, we have the largest multiple sclerosis clinic at St. Michael's Hospital in North America. And one of the things our neurologists struggle with is, I have to see Mr. Jones at 4 p.m. and I know I don't have all the information I need, because Mr. Jones has been in our clinic for 7 years. There are pages and pages and volumes of information on Mr. Jones that I don't have time to go through before my next visit with him, because I'm seeing another patient right before him. I've got 10 minutes. So how can I possibly know that Mr. Jones, and remember and process that Mr. Jones had a relapse of his condition 6 years ago, and then 12 months later had another relapse, and 3 months later had a new T3 lesion in his brain, and then 6 months later I changed from Copaxone to some other medication to treat him? It's a crazy amount of information. And Mr. Jones may not also remember, and may not also be so forthcoming, because he doesn't feel as comfortable with the position, or feels like, I don't know enough to say anything. But Mr. Jones actually probably knows more about his own history than the clinician does, from very simple perspectives. So again, from an AI perspective, what we've been able to do, and we've launched this in a pilot phase right now, is we've sympathized with the neurologists and said, wouldn't it be great if we had an artificial intelligence process using natural language processing, some advanced methods there, to literally read through your notes for the past 7 years, and within seconds summarize the key points that you need to know in a graph, not in text, in a graph. So you can imagine a timeline of Mr. Jones, where it would actually highlight Mr. Jones had a relapse here, 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 and here, had a new T3 lesion here. You started him on this medication, but then they changed 4 times to these. And if you're interested, you just click on one of the boxes and it will pull up the note from that visit, so you can remember exactly what happened. The new T3 lesion, it'll pull up the radiology report to tell you. Oh, and on the left-hand side, we have a predictive algorithm that will tell you that according to Mr. Jones' current trajectory, he may end up in a wheelchair in 12 months. So we need to be a bit more aggressive in his diagnosis and management. It's these sorts of things that I think will help bring people together. So the clinician can then say, wow, I didn't know. I have all this information at my fingertips. I'm going to ask Mr. Jones a bit more. And hopefully that will make Mr. Jones more comfortable to say, okay, you do know more about me, and maybe I can open up a bit more and have more of a collaborative relationship with you.
Sounds like AI and data analytics is going to change the job of a doctor dramatically.
I would hope so. I really see that this is where we're going. I mean, again, I go back to other industries. When we look at the transportation industry, the taxi industry has been radically changed by Uber. And, that's using technology, and a lot of, they actually use quite a bit of AI in their algorithms. But, I'm looking at the Uber drivers and I'm thinking, self-driving cars, when those come, that'll change the game as well. We have to understand that these sorts of technologies are going to change healthcare as well, and we have to embrace it.
So what are you doing? Obviously you're working both at U of T and at St. Mike's in this regard. You're doing something in a couple different sort of pilot programs and test programs. Give us a sense of how this rolls out.
Yeah, it's a newer role at U of T, which I'm really excited about. So we have launched the Telemetry Center for Artificial Intelligence Artificial Intelligence Research and Education in Medicine, so CARIM. That is really to bridge the U of T community together, to have a central point for AI in medicine.
Let me interrupt you just for a second. You talked about there being a lack of collaboration in healthcare. I always heard that one of the areas that's most stuck in silos more than anything else is the universities. Is that true?
We have a lot of silos at the same time. It's a pretty massive organization, so silos almost are expected, but we should be working towards breaking those silos. And so you can imagine, Sick Kids has some really neat stuff going on. They've got an algorithm that predicts pediatric heart attacks. That's great stuff. We've got UHN developed some really neat stuff around heart failure in particular, for example. We've got St. Mike's doing some wonderful stuff, Sunnybrook. We don't really talk a lot, though. And we have a lot of people in medicine who are doing great work, but really to get at AI, you've got to bridge computer science, statistics, all these other disciplines. And there isn't really a focal point to do that. So that's where I'm hoping the center will actually be that focal point to bring people together, to collaborate so we can build even more effective tools to benefit society.
So give me a sense of some of the things that you think will change. What's going to happen in intensive care?
Yeah, intensive care is ripe. One of the world's biggest problems in Canada, I think most intensive care units are still on paper. So we got to fix that first.
Right.
But there are many examples out there right now where I think there's lots of potential where in intensive care, it's such a unique environment where you have a patient who is very vulnerable, who is on lots of monitors, who is being recorded in terms of all their vitals and their parameters second by second. An incredible amount of data and information. And where I see things headed, and other people are already on this, and I think we will have to do some catching up, is that you can imagine an ICU patient with an AI algorithm constantly monitoring them every single second, getting a sense of, is this person's blood pressure going to drop massively over the next few hours? Is this person going to end up septic with a massive infection over the next day? And that will basically give us alarms and a heads up in terms of what to do to make sure that patient doesn't crash as hard as they could. The other thing it'll do is it'll automate things. So for example, we're always pushing around with insulin doses. And that takes a lot of time and energy. Well, could that not be automated? And in fact, in some insulin pumps for outpatients, it is automated and it works reasonably well. But those are the applications we could have in healthcare in terms of automation and prediction that I think AI could radically change things for us.
What about mental health, addiction? Any use there?
Yeah, there is an incredible amount of use, but I have to say that's got to be one of the most challenging areas for anybody, really. I mean, we really struggle with mental health. I think that's number one, it's been historically under-resourced. Historically, we haven't put as much energy or time into this space. And, we don't know a lot about it. It's very, very hard to quantify emotion. And some people will say that we can do it. And I agree, to a certain extent we can. But it's difficult, especially when we rely in healthcare on getting information from people. And if generating that information, if conveying that information is challenging for patients because of their mental health condition, we're automatically at a disadvantage. So there are technologies out there. MIT is actually great in this space, but CAMH is doing some pretty great work. There's some centers who are doing some really great work around how do we get stuff into people's brains or read from people's brains. They don't have to tell us, but we can read from their brains what's happening. I think that area is going to have a lot of potential to grow, and we need that area to grow.
I was aware of and slightly involved in a clinical trial for an antidepressant, and I was surprised how qualitative the endpoints were. It was almost just, do I feel better or not? Isn't there some way of better analyzing whether an antidepressant can actually improve someone's mental health?
Yes, that's a great question. There are validated metrics out there. There are actually tools that have structured questions. And when you ask those structured questions, it's been validated to show that there actually is a reduction in depression in an objective way. But I would also argue that that's great. Those are just numbers. So numerically, you can show that you've improved on the depression scale. But how does the patient really feel? And that's the challenge in mental health. where in many cases what we'll find is these instruments are not perfect. We'll actually improve on the instrument, but the patient will say, I still feel crummy. And then the challenge in mental health is, well, wait a minute, do they really feel crummy, or is it right now and then 2 hours later they feel a lot better? Mental health is such a challenging space. I think it has a lot of space, a lot of potential to grow. But I would say if I had to pick one area where I think AI could be beneficial but is challenging just clinically, it's mental health, hands down.
We're chatting tonight with Dr. Mamdani, a professor in the Faculty of Medicine at University of Toronto, on staff at St. Mike's Hospital, and he's the Vice President of Data Science and Advanced Analytics at Unity Research Toronto, the Adet Chair in Advanced Analytics. We're going to take a break for some messages and come back with the professor for just some final concluding comments. Stay with us. Welcome back to the Brian Crombie Radio Hour Saga 960. Fascinating conversation tonight with Dr. Mohammed Mamdani, who is a professor at U of T, a pharmacist. He went to Wayne State. He went to Harvard University with a focus on statistics and epidemiology. He's got a master's in public health. He's got a master's of arts in econometrics. So he's smart with numbers, and he's smart with public health, and he's smart with models, and he's smart with algorithms. And now he's trying to change things from artificial intelligence and the data analytics standpoint. Professor, Doctor, with bionic limbs and biometrics and more powerful, smaller MRI machines, and then data analytics and artificial intelligence, the world's changing dramatically. Mm-hmm. I read this fascinating book by an Israeli author called Homo Deus. I'm not sure if you're familiar with it all, but what he does is he thinks that we're almost going to have a different species of human in the future, those that have got the benefits of all of this new science. And he says, regrettably, it's going to be the rich that are going to be able to make use of all this, and the regular people. And he almost compares it to the way that humans, Homo sapiens, dealt with Neanderthals, that even though we were sort of cousins in the human race, we dealt with them as inferiors. Are we at risk of that?
I think potentially we are. And there are people who have very strong feelings and opinions about this. All we have to do is look towards some of, I hate to say it, but the sci-fi movies and the popularized, Star Trek type stuff. And I got to say, sometimes when you look at these movies and watch these shows, we think, wow, that's really neat. That'll never happen. I don't know. A lot of those things are happening. And if we talk about things like Neuralink, for example, with Elon Musk's experiments these days, there's a chip in a brain, right? For over the past 10, 15 years or so, there have been people who have been injecting chips inside themselves, into their forearm in particular. It's not unreasonable to expect those sorts of integrations into humans over the next 10, 20 years. I might sound crazy to some people, but I do believe those things will happen. Who will get them first? Probably people who can afford them. The more developed countries. Will that cause equity issues, inequalities? I believe it will, at least in the short term. And by short term, I mean 10, 20, 30 years. The longer term view is that I imagine that we will all evolve to this where we're not going to become cyborgs or anything, I hope, but I do believe that we will have considerable assistance, let's say, from smarter systems. If you actually think about it now, how many of us are glued to our cell phone? A lot of us, right? We're constantly checking what the latest scores are for our sports, or what the news is, or our Instagrams, or whatever, to see what the latest messages are. I mean, the only difference is that it's not part of our body right now. Could it be? I don't see why it couldn't. Could it be internalized? I don't see why it couldn't. It's an interesting future ahead of us.
So it's a moral question, ethical issue. What do you think the answer is? Is there an answer?
I don't know. And I struggle with this personally as well. When I look to the future, is how will this technology evolve? It should evolve, because that is progress. but how are we going to have a fair, equitable, just way of distributing this technology to people who need it the most? And it's sobering to me, because the more I think about it, the more I come to the realization that the reality is it's not going to be equitable, at least in the beginning. It's not going to be fair. And I wish I had an answer for how we could make it fair. I just don't.
Well, I think number one, if you haven't read the book, I commend it to you. It's an interesting read, scary but interesting. We're also going to be facing this with the vaccine if we develop one, aren't we? And you know, some of the nationalism, parochialism that's come forward already, where people are trying to get access to the vaccine for only their country first. And then I wonder, you know, how is it going to be distributed? And people talk about first frontline workers getting it first in healthcare and the like. But then I worry that the rich are going to get the vaccine before anyone else. And how we distribute this vaccine out of this current pandemic, when and if it comes, will be a test of our ability to be fair and equitable. Will it not?
It absolutely will. Yeah, there's going to be a lot of lessons learned for sure. It's hard though, right? Because to your point, I mean, if we look at the global context, which countries are going to get the vaccine first? Luckily, there are initiatives that are trying to make this more just and fair and focused on the developing countries. At the end of the day, though, I imagine money does talk. We're very, very fortunate to be living in a country that can afford to have vaccines for everybody. And we will get them earlier than many other countries, I imagine, but even internally within Canada, I think we will have to have some rules around who does get it first, and it likely will be the healthcare professionals and the frontliners and the more vulnerable populations. I would argue that's actually quite reasonable and it's fair, not because I am in that category, but I do think we need to actually look at the vulnerable first. That being said, are there going to be other people who get it who are more influential, quote unquote? I imagine that will happen. I don't really know how to control it. I wish I actually had went to get a master's in public policy as well. Unfortunately, I don't have one. And I don't envy the people who have to make those decisions.
One more degree to get to add to the list that you've already got. You know, machine learning, artificial intelligence, data analytics have changed the world, and I think will change the world dramatically in the future. And so it's a real honor to chat tonight with Dr. Mamdani, a professor at the Faculty of Medicine at the University of Toronto, on staff at St. Mike's Hospital, and the Vice President of Data Science and Advanced Analytics at Unity Research Toronto, a Debt Chair in Advanced Analytics. Doctor, thank you so much for joining us tonight. Really interesting conversation.
Thank you so much. Really appreciate being here. Take care.
Well, that's our show for tonight. Tune in every Monday through Friday at 6 o'clock, 9:60 a.m., or stream us online at www.saga960am.ca, or you can get all my webcasts, videocasts, podcasts after the fact on my website, briancrombie.com. Thanks. Good night.